There we go. Again, welcome everyone, and welcome to today's webinar. It is great to have you on this Friday afternoon. I hope you all are staying cool. And let me start the show here. All right, I hope that's working for everybody. And I wonder if I'm going to be watching to let people in. So I'm going to try to show the attendee folks. Here we go. There we go. And the people who are asking. Great. Okay. Sorry about that. Hello, everybody. Again, I am Meg Laporte, and I am the Executive Director of the Maryland Regional Direct Services Collaborative. I am very happy to be here today with Regina Figueroa, Melody Nwokolo, Robin Stone, and Holly Ward. And we will have you folks introduce yourselves when we get to when you speak. And we just a few housekeeping items. Thank you for joining us. If you could keep your phones or computers on mute until we get to Q&A, to the Q&A portion, I'd appreciate it, just to keep the noise down and distractions down. I just want to, today's webinar is about nursing home and assisted living direct caregivers and examining their unique challenges and possible solutions. And this is part of a series of webinars that an initiative funded by the ABLE Foundation that is examining improving quality, job quality for direct care professionals. Oops, I have a typo on my slide. Sorry about that. Direct care professionals in Baltimore and beyond. And after, by the way, so after this webinar, this is the final webinar in that series. We will be releasing 2 issue briefs related to the 4-part webinar series that we've had. So we will, obviously, we'll be sending them to everybody who's attended and all of our email list. And I'm going to check the chat real quick. Oh, hello, Abby. Thank you for being here. And oops, sorry, I'm getting ahead of myself. Oops, and I have to admit someone else. Hang on. Sorry, I'm running everything. Forgive me again for all my technological challenges. So I just want to say, for several of us on this call today, including myself, are actually helping with the Longevity Ready Maryland initiative. Some of you may be familiar with that. It was an executive order signed by the governor earlier this year, and leading it is the Maryland Department of Aging. And they have created a series of work groups for folks to work on the multiple issues related to improving and preparing Maryland for being aging ready, longevity ready. The work group that I am on and several others on this call are on is the direct care or direct caregivers work group. And a lot of the work that we do with the collaborative and this work too will help inform that effort. We're going to be producing a report that we're going to give to the Department of Aging by October. That includes recommendations. So. And just I just want to go through a few statistics. I know that some of you probably already know this, have seen this in past webinars, but I think it's really important here just to repeat, just so we continue to know. And also, you may be seeing these statistics again because we don't have a lot of data or recent data on direct care workers in Maryland. So there are, just so in the US, this is a snapshot. I took this slide from PHI. Thank you, PHI folks. There are 4.8 million workers in the United States supporting older adults, including individuals with disabilities. And 2.8 million of them are home care, 719 are residential, and then another almost 500,000 are nursing home direct care professionals. They are predominantly women and predominantly women of color or people of color. And so with regard to the Maryland folks, sorry, I'm having another technical issue. With regard to the Maryland, specific to Maryland, there are roughly 26,000 nursing aides, nursing assistants, CNAs or GNAs in the state of Maryland. Again, predominantly women, people of color. 40% are immigrants, and their median annual earnings are around $27,000. 40% of these folks rely on public assistance. Again, this is sourced from PHI. Thank you, PHI. And one more from PHI here, just with regard to Maryland and DC. And this data is a little bit older. Well, I think it's from 2023, actually. The median wage in Maryland was for direct care workers was $14.62. Public assistance, again, 40% of them. In DC, the median wage is a little higher, but there's a whopping 71% of direct care folks who are on public assistance. And some of you may have seen this. This just came out today, a report from the Long-Term Care Community Coalition. I believe, they call themselves a watchdog organization for long-term care and nursing homes. And they just came out this report where they looked at data from CMS, and they at what they call problem facilities, and they also examined special focus facilities. Some of you are probably familiar with that designation. It's a CMS designation where a nursing home has many problems and they need to get special attention. And as you can see here, there are apparently in Maryland, I pulled out the Maryland and the DC data from that. And then up top or on the right here on this slide are the US stats on this. And so in Maryland, as you can see, there's there are 222 nursing homes, one special focus, 5 that are candidates, 43 that are one-star facilities, and apparently that translates into 22% that are they call problem facilities, which includes special focus, the candidates, and the one-stars. Interestingly, 73.7 of them are for-profit, the 24% are not-for-profit, and then a smaller number are the government-owned. And so DC has 17 facilities. It's nice to see that 0 are under special focus designation and 0 are candidates. There are 2 that have 1 star. I think this is just a helpful information in the context of our discussion today. And again, I know I've shown this again. This is from a report that the collaborative did released last year. It was part of we included this information in the report. This information is a survey that came out last year from the National Association of Healthcare Assistants. They represent CNAs, primarily CNAs who work in nursing homes. And I just like to point this out, that when we ask them what motivates you or what has motivated you to leave your job, of course, the leading response is that the pay is too low. And then with regard to, and then this other national survey also is, and you'll have to forgive me, I'm sorry, let me just correct myself here. I think that the one I just talked about, came from our own survey. Forgive me. This survey is from the National Association of Healthcare Assistants, and their response to questions about the biggest challenges in their job. Their primary challenge at the time of this report last year was a CNA staffing shortage. In other words, working amid a short-staffed environment was identified for them as being very challenging, as well as, interestingly, the nurse staffing shortage, followed by working with CNAs who they believe were not trained properly, and then lack of respect from their supervisors or colleagues, and then burnout and exhaustion. This is another some more data from the Baltimore report that the collaborative did for nursing homes in Baltimore, and we asked them if they were to leave, if they have left or were to leave, what would it take for an employer to hire them back? Again, better wages and benefits was at the top of that list, followed by better staffing ratios, or having more, as I just described, have better staffing ratios in their shifts, working in environments where they have more, the ratios are better and there are more CNAs to help care for residents. And these are just some quotes. Again, I pulled out from the report, from the Baltimore report that we released last year. These are from CNA focus group interviews. I think it illustrates the dedication and the desire for CNAs to work for what they love to do. They love working. From my experience in doing these focus groups and knowing other CNAs, they really enjoy, many of them just really enjoy their work and working with older adults. These are quotes from employers that we did, also interviews with employers that I did for that report last year. One of them, these quotes indicates that someone with a nursing home said that they had been using staffing agencies, but things were getting much better. And I'm curious to know, I would like to hear, maybe Regina and some folks on the call can talk about that too, if that's getting any better. I want to talk about some recent something recent that's happening in the space, and that is around trauma-informed care. As probably many of you know, CMS has a directive that nursing homes ensure that residents who are trauma survivors receive culturally competent, informed care. And this effort that is been done by my my colleague and friend named Jean Hartnett. She is with her organization that she founded is called Radical Sabbatical. And she partnered with a company called CARE, K-A-R-E. They're a staffing company. They did a survey of like 1,400 CNAs and nurses and CMAs, and discovered that and they had them do their ACE score. Now the ACE is, and forgive me, I'm not an expert on trauma, but I think this is all very interesting information, and again, informative. And ACE is a survey, it's a quick survey about childhood trauma that they asked. So they asked these direct care workers to do their ACE, do the ACE score, and this is what they found. In the US, the population in the US, the average population has at least 64% has at least one ACE score. They found that amid this care force, the nurses, CNAs, CMAs, that there were, and LPNs too, that there were a higher number had at least one type of ACE. And then 17% of them had fed 4 or more one type of ACE amid the general population, compared with the care force, which was 34%. This is part of a report that CARE has put out. They're going to be putting out 2 more reports. The next report is going to examine the impact of the pandemic and trauma on the care force. And that is actually all that I have for the slides. Thank you for going through them with me. I appreciate it, everyone. And I'm going to start with Robin. And first, I'd like to ask you, Robin, what is your reaction to some of the stats that we just discussed? And then I'm going to ask you some other things too. So, and
sure.
Sorry, could you introduce yourself too?
Hi, everybody. I'm Robin Stone. I'm the Senior Vice President for Research at Leading Age, which is a national association of primarily not-for-profit aging services providers across the full spectrum of settings, from post-acute to adult day, home care, hospice, independent living, affordable senior housing, life plan communities. We've got them all. That's what's so very interesting about our association. And I also run our Leading Age LTSS Center at UMass Boston, which is a research group that I started 25 years ago that is has a collaborative relationship with the Gerontology Institute at UMass Boston. So what do I think about the data? What Meg reported is not surprising. Actually, for many years, PHI has been either the sole source or the primary source of data on frontline care professionals. That is changing, and that is exciting to know that we have finally gotten to the point where more organizations and the feds, the states, and many others are now beginning to pay attention to that direct care workforce that was really invisible for many, many years, would show its head, rear its head a little bit sometimes when the economy was in a state where we were having shortages, but COVID really shined a light on not only the need for this workforce, but the important benefits and the competencies that are required to do this work. And I'm hoping this is never going to go back again. One of the things that always strikes me in looking at these data are that we are really talking about the working poor often, when you think about the fact that nationally 40% of this workforce receives some type of public assistance. And these are the folks that are caring for our most vulnerable older adults and younger people with disabilities. It is a travesty to me. And to those of us who have been working on this, both from an advocacy perspective and from a research perspective to try to change policy and practice. So there's really good things to celebrate, I think, about the demographics of this workforce. Very diverse, which is exciting. I think that's what adds to the wonderful mix of folks in our nursing homes, assisted living, and other settings. A large proportion are immigrants, which again, I celebrate in terms of the diversity and the knowledge and the shared cultures that we have in our various organizations. But with that comes some serious challenges around economic situation, wages and benefits, quality of the workplace, attitudes of society towards this workforce that I think need to change dramatically.
Thank you, Robin. I appreciate that. I just saw that, I don't know, I think also relative to this, I just saw in Maryland this morning, there was a headline about the head of the Office of Healthcare Quality, and I'm sorry, I'm getting OHCQ, is that the name of it? Has resigned, and they believe it is probably in response to a lawsuit that was filed by the Public Justice Center and Justice and Aging, because nursing homes in Maryland are like second to last in the having surveys. And I wonder if you have some opinion about that.
Well, it's a systemic problem. And that's one of the challenges, I think, of working in this sector, having been in this for almost 50 years and spending my first 25 years more doing policy work at the federal level, in the Department of Health and Human Services, and doing applied research at the federal level. And then for the last 25 years being at a provider organization where I'm actually on the ground. I mean, I've been in hundreds of nursing homes, assisted living, home care settings over my years of doing this work. And, I think that the challenges of a highly regulated situation that really hasn't necessarily produced the kind of quality that we need in our nursing homes, not because there wasn't good intent, but because the real culprits in the nursing home setting is the fact that we don't support a workforce that does 60 to 80% of all the work. And so if you want to produce quality, you don't need a rocket science degree to understand that quality comes from the people who are doing the work. That means they have to be trained, they have to be supported, they have to be paid well, they have to be able to do the work that they are trained to do. They have to be heard so that they actually can influence the care that is being provided. And the survey and certification process needs to hold nursing homes accountable. So we have this whole broken down system, and part of the survey process is the question of whether the state has been investing over the time in the survey and cert process, and then are they investing in the right things in terms of actually supporting quality outcomes for both the staff as well as the residents. And so it's like you push one side of the elephant, but another side of the elephant pushes out because there's so many pieces to this.
Right.
And it's not surprising that, this is what we end up with. So, if we had to do over again, and the one thing I always say is we created the modern nursing home was really created in 1965 when Medicaid was introduced, and we paid for nursing home coverage through the Medicaid program. That started the modern nursing home. If we were doing the same thing today, we wouldn't do what we did in 1965. We wouldn't have built what we built. We wouldn't have created a system that undervalued the staff that's doing the work. We would have done a whole lot of things differently. And so we're trying to play catch up like 60 years later, and you can't blow the whole thing up and start all over again. So I love the fact that at least we're working on the part of this that I think we can make some changes in, which is how do we support, train, support, provide career advancement, and all the opportunities for the frontline to do their quality work. Because if that happens, we're going to see quality outcomes. And you cannot figure out how to do that without that kind of investment.
In your opinion, then, Robin, with regard to the challenges, the workforce, direct care workforce challenges in the country and in Maryland, then do you think that what you just described, training, better quality training, better training opportunities or an advancement for CNAs and GNAs are a major part of the solution, a major possible
I mean,
solution?
I do, you know, we look at different variables that affect outcomes. And we've done studies of national databases, which unfortunately are very old. The last time we did a national survey of CNAs was in 2007. And actually CDC is trying to get a new study started, but it's very, very difficult. We don't have the investment in that data side of it either. But the data that are clear in all of that is the most important variables are certainly pay, compensation, and the idea of a living wage that people can live on, but also the attributes of the workplace, and particularly around management and supervision, and the opportunities for career advancement and good ongoing in-service training. So it's not just what you come in with, but it's also, are we trained up to the minute in the latest techniques for doing good care? And then how do we empower the front line, who does the vast majority of the work, to actually not only be part of teams, but actually to lead teams? And so, you know, I often highlight, because we have a shortage of workers in many places, but your solution cannot be to continue to hire. The solution has to be in retention. It has to be in developing and strengthening the workforce so that folks stay. We have interviewed thousands of aides in my time. Many aides consider themselves in a career. They don't want to become necessarily a nurse. Maybe they want to become the head of an HR department, or maybe they want to do social work or something like that, but they don't all want to move up. They want to be aides. They may want to be a specialist in dementia care or medication management, but we need to develop these careers and we need to be paying for them. And that's going to cost more money. You know, whenever we talk about a living wage, we have to be honest with the public that the living wage and recognizing careers and building a quality workforce costs money. But at the end of the day, every time you have a turnover, that costs substantial amounts of dollars that is never figured into the equation. So I think we've got to work on retention and get the elements that build and support a quality workforce. At the same time, thinking about a pipeline that has to be built on getting young people interested and seeing that these are viable careers, looking at older workers who may have the potential to stay on for 20 more years if we design the jobs properly. And certainly immigration policy is going to roll into this, because 25 to 40% of the workforce in Baltimore are immigrants. So can we deny that we are not going to need good immigration policy to support good quality? And so all of these things have to be taken simultaneously.
Thank you. Thank you very much, Robin. So I'm going to ask Holly and Melody if they could possibly respond to what Robin just described as what she believes is going to take to solve the staffing workforce crisis. And I'm wondering, so Holly, I'm going to ask you, if you don't mind, introducing yourself first. And Holly, you work at Keswick, correct?
That's correct. I'm a GNA there. I've been there for 6 years. And what Robin stated is very true. We have to get retention with the aides. We have a lot of aides that come in, but for some apparent reason, they decide that there's to keep them staying inside the facility. To be truthfully honest with you, Keswick is one of the better facilities that they have in Maryland. The patient ratio is not that, it's not bad, as opposed to some places where on a bad day at Keswick, you might have maybe 12 residents, and maybe one of them is self-sufficient, but just needs minimal assistance. Whereas I have been to other facilities like Future Care Irvington, where on a regular day, I had 18 residents every day. And so Keswick is one of the better ones, but I don't understand why we are unable to keep aides coming there. You know, and then also too, the majority of the aides at Keswick are 50 and up. And sometimes they get tired and burnt out. Sometimes they're a little spoiled and they're looking to the back in the old days, but they have to realize it's not how it was back in the old days where the patient to aide ratio was much smaller. So I don't know, we just need to get more staff inside there. Also too, we have to get more team players. Everyone has to work together and they have to be under the understanding that our purpose there is for the residents. It's not there to, it's not to be there to, you know, get cliquish, or it's also not there to say, well, oh, I'm above to do certain things. No, everybody has to pitch in. And that's the understanding that we have to come across. Also, too, the aides have to feel appreciated. Because to be truthfully honest with you, we are the backbone to the nursing homes.
Yep.
We know when the residents are sick. We know when they're not feeling well. We're the first ones that know everything. Sometimes we become their, you know, surrogate family because we're there with them every, you know, we're touching them in personal areas that normally someone would have to ask. So I don't know.
Thank you. No, that was really helpful. I appreciate that. So when it sounds to me, you described when you said you think having team players is very important. Is that part of that? You don't always feel respected as a team player, or that you're feeling like they're not, that your colleagues maybe are not wanting to work as a team, or they're feeling, what's that? I'm just curious.
I feel that, okay, like I said, I feel that some of the aides, and I'm going to say me, for instance, okay, my thing is this, is that everyone is there and they see what's going on. We have some, you know, co-workers that feel that they're above helping with the residents. As far as when meals come out, I feel it should be all hands on deck. That includes nurses. It doesn't only include the aides, it includes nurses. When it's time for the residents to be fed, everybody should be feeding. It shouldn't be an assignment of you have this person, you have that person. No, everybody. And once you finish feeding one person, then you move on to the next person. But it shouldn't be that a resident is waiting to eat. It shouldn't be that if a resident wants a cup of water, that you come and you look for the aide and tell the aide, oh, this person wants a cup of water. You can do the same thing that you just told me. Go get them a cup of water.
Mm-hmm. Thank you, Holly. Melody, I'm curious if what your response might be to the discussion here with Holly and Robin in terms of the solutions for dealing with the workforce crisis. And you could introduce yourself too.
Hi, I'm Melody. I work here at Keswick as a preceptor for GNAs, and I've been here for a little over 2 years.
Great. And so what is your response to Holly and to Robin around what are some of the solutions for resolving what we are, this workforce crisis, and the difficulty with retention? It seems like there's a lot of that even across the country.
I agree with both Robin and Holly, especially when we're talking about foundation. When we talk about foundation, and Robin mentioned the changes that have to come. And we all know with foundation, that should be built solid when it comes down to, let's say, the GNAs.
Mm-hmm.
You can always change that foundation, but it cannot be destroyed.
That's correct.
So
right.
when we're moving forward in futures to come, generations and things like that, we're dealing with diversity of age groups,
Mhm.
populations, and as Holly said, teamwork. We're gonna be mentors because we've been here for a long time.
Correct.
Mhm.
So we're gonna have to teach them teamwork.
Mhm.
We're going to have to show them how to apply it, to others.
That's true.
And far as teamwork with the nursing staff, that should be set in place to begin with. That's something that we shouldn't even have to complain about. It should be set in place. And all we have to do is come in, be motivated to walk it out.
That's true.
And that's important. It's not just to the GNAs, it's important to the nurses and the residents.
Mhm.
Yes.
Yes.
Yeah,
You're
if
right.
I could just say one thing here, I mean, I think this is why leadership is not sufficient, but essential, because you have to set that foundation. I mean, Melody, you just articulated it, and Holly too, is that so you could have a great charismatic leader, and that wouldn't be enough because you have this front line. And, Holly, we've been in places where some of the CNAs are eating their young. I mean, I have seen all out warfare and doing end runs around nurses. I mean, the culture is quite interesting. So, and often the CEO has no idea what's going on in the organization, none whatsoever. So it is a system. It is a workplace. It is a system that has to be thought about. And, this leadership piece is critical too.
Yeah.
And how many people listen to the frontline folks, the professionals who are doing this, and have them say, this is how we should do teamwork. I'm working with some folks right now. They don't include aides in the conversations around teamwork. I'm like, why are they not directing what's going on here?
Yeah, yeah. So speaking of leadership, Regina, not to put you in the hot spot, but I guess you are. Regina, can you
am,
introduce
and I'm
yourself and
okay.
respond to that. Yeah.
Definitely. Hi, everybody. I'm Regina Figueroa. I'm the executive director here at Keswick Multi-Care Center. I have over 25 years of experience in this industry profession, and I do love it. So with that, I am proud to have Melody and Holly speak on their experience, and they've got a vast majority of experience, not just here at Keswick, but at other places and areas of healthcare, probably within the state of Maryland. But as that, yes, we definitely have to be a team. And what Robin said, it's quality, not quantity. I was talking with Melody and even Holly yesterday. It's the training. We need to invest in training what we have. And then looking further, we were talking about how many years ago when you could graduate high school with a CNA or a GNA, or even some graduated with an LPN. But it's instilling that care and this career path at a younger age. Building that workforce, that work ethic to care for someone else. Here at Keswick, we started our CRC, which is our Committee for Retention and Culture and Retention. And that was started prior to my arrival, but it came from employee feedback, our surveys. So we reach out at least once a year to all of the employees for feedback, for their voice, for their involvement. We try and do some training as well. Recruitment has been hard. It still remains very tough. We are fortunate that even with this new increase in the staffing, the staffing mandate, we are above it already. But the hard part is, I was telling Melody, we think we're okay because we schedule it. But again, that culture of the new group or the dynamics of our GNAs and our nurses, we schedule them, but we have time and attendance issues.
That's correct.
So there's a lot into the pot. It's recruiting them, but then making sure that they come in with, when we talk about education, customer service education. Are they that? I don't think that's a part of the curricula for a GNA or a nurse. But we have to provide that, dealing with conflict, working with each other, teamwork, that unfortunately is a skill, is something that we need to reinforce to make it happen. Here at Keswick, I do believe that our managers and leaders work with our line staff, and we are able to listen and talk and share in the good times and the challenges. But there's a lot to be done, and I don't think it's going to be in just continuing to recruit, like increasing the number. It's not the quantity, it's the quality, and it's how are we getting them educated before they even think about going into healthcare? How do we get them to come to long-term care and caring for seniors, not the holy grail of a hospital? Everybody wants to go work in a hospital. How do we incentivize them to try at least 1 to 2 years with seniors? You get some type of an incentive, and then you can try another area. But that's where we need help as far as recruiting and education and training of our workforce.
So are you saying after recruiting them,
Mhm.
how do we maintain them being engaged?
Yes.
So yes,
Correct.
engaging them, then that is our role as leaders. And when we say leaders, it's not just the CEO or the executive director. It's not just me and one person, it's all of us, that teamwork Holly was talking about. Everybody here is a mentor. Everybody here is a leader. And we all have to do that and be able to talk to each other. As I say in the town halls or employee meetings, we have to be able to take criticism from each other.
Right.
A housekeeper can tell a GNA, okay, that didn't look right. Was that the way to talk to a person, or was that correct? A GNA can tell me, I don't think you were supposed to do that, or you didn't take your gloves off right. It's use this hand sanitizer before you go into the room.
Right.
We have to be able to be in an environment where we can talk to each other, good, bad, and different, because as Holly said, it's all about the resident.
That's correct. To piggyback off of what Regina and Melanie just said, you have to be an example. If you have a new employee coming in and seeing that you lackluster or that you lagging around, then of course that's what they're gonna think. Oh, it's okay to do that. No, you have to be an example. My thing is this: is first impressions are lasting impressions, and you never know who can come inside that facility. And my thing is this: is that you want their impression of you or that facility or that unit to be a positive one. You know what? I see that this person cares about my family member. Or I see this person, when I ask a question, however minute or however petty it is, they get up and they respond. They feel good. I'm gonna give you a perfect example. We had a resident that went out to the hospital. And when they were in the hospital, the first thing that staff said is, what nurse, are they coming from a nursing home? And it was like, yes. They was like, well, what nursing home is that? Because this person has no skin issues. So whatever facility that this person is at, that nursing home is doing what they're supposed to do. And you know how good that felt for a family member. Now, mind you, this is a family member that's, pick. But for them to come out and say that they went to an institution and at that institution inquired, were they coming from a nursing home, gave a positive affirmative guess, and what nursing home that resident came from, was a good thing to say.
That is
was
awesome.
a very good thing to say. And that's what we need. You understand what I'm saying?
Awesome.
That's good for morale. Also, too, it shows you that your caring and your commitment is being appreciated. You understand what I'm saying? Because you never know. You never know where that person will go at. And no matter if they're in the facility or they're someplace else, there's always a representation of where they're at or where they came from.
It's such a fabulous example. I mean, I always say, I wish we could clone these quality cultures, because it's not rocket science, but it is hard, obviously, because we don't get most of our organizations doing the kinds of things that you're doing. I mean, bringing Holly and Melody together, talking about a preceptor who's doing preceptor work in an organization. I mean, many of our nursing homes say to us, we don't have time to have preceptors. And I'm like, you don't have no time to not have a preceptor.
Right.
I mean,
Can't afford
the
not
whole the whole process of onboarding and ongoing mentoring and the difference in what you will get when you have a culture that is supporting staff who are not going to turn over, where you don't have to go to agency. I mean, and the money that comes out of that, the return on investment, to speak to the people that only care about the money or care mostly to get to those CFOs to say, you know, you're not counting how much we're losing every time we do this. And so why not invest in this whole person investment on our workforce side? So making those connections are critical. It's not the only answer. I mean, policy has to change too, because we've got to be able to support this at a higher level. But there is a lot that employers can do. And coming from a leading age membership organization, we try to get that out there all the time. It's not just going to be a solution from above. It's going to come from your own organization.
Thank you. I'd like to encourage folks, if anybody wants to ask a question or come on, please feel free to raise your hand or unmute yourself as we continue our discussion. Something that occurred to me was there are many efforts out there right now to solve the workforce crisis across the country. We've got Moving Forward, this initiative called Moving Forward, which is a national initiative funded by the Hartford Foundation. We've got something by the National Council on Aging. They have a workforce center. They're mostly focused on, I think, home and community-based care. And then CMS is actually in the process of developing a recruitment campaign. And I'm curious to know first, which is interesting to me, is that first of all, NCOAs is just focused on home and community-based, and I feel like that probably there should be something that all of the efforts should actually focus across all of the settings, because from what I know is that folks who work in these settings is fluid. They work in all different settings. They don't necessarily go to nursing homes and stay in nursing homes or vice versa. And do you have any thoughts on that? Anybody?
Well, I do. I mean, I personally think that we ought to be developing universal care professionals that actually could work across all settings, that training ought to be setting agnostic, because COVID is a perfect example of when we had extra home care aides that were working in home care that could not go into the home, that could have been working in nursing homes, but couldn't because they weren't trained to be a GNA. That was a travesty. We lost staff that could have been doing this. And I think that we've got a lot of fluidity. Folks go back and forth. We've seen that. And the opportunities for a universal profession, when you're a nurse, right? I mean, you can go into different places. You've got a license. With our professionals, they get trained for work in assisted living, or they're trained to work in a nursing home, or they're trained to work in home care. It makes no sense. It actually isn't good for the providers or for the older adults and their families either. So I'm a strong proponent of good, high quality, universal, with parity in pay.
Right.
And an investment, again, you're going to have a lot more with less if you actually were to create that kind of a system. So I know PHI is very, very strong behind that as well. So
Robin, we are at Leading Age, we learned that there was legislation or things that have changed with the Department of Nursing, where by the end of next year, we will just have either, I'm not sure what they're going to call it yet, they're just figuring it out, but there will be no difference between a GNA that can't go work in assisted living or CNA that can't come work in a nursing home.
That's great.
That's
fantastic.
Figure that out.
That's fantastic.
Does that mean they're phasing out the requirement of the GNA? Is that what that is part of, or?
There's a process. It wasn't really clear how they stated it, but basically they said hopefully it wasn't just semantics where they were changing it from CNA and GNA. In the wording, it said CNA level 1 and CNA level 2. But
that's great.
The end outcome should be that a CNA should be able to go from an assisted living to a nursing home to home care to any entity.
Yeah, and then the next thing I would say is you need portability across states, because if you've got a region like we do with Maryland, Virginia, and DC, people are going across these lines. They don't live in necessarily one place, and they got to get trained, and their requirements are totally different depending on where you live. So, it's very complicated in the United States because we're so big and we have so many different rules and regulations. But at least to start paying attention to this workforce as a career rather than somebody just being in one setting, I think is terrific.
Yeah, thank you. Thank you, everybody. And we're going to get to, we have a question from Susan. Thank you, Susan.
Can you hear me?
Yep.
Okay. I'm the healthcare agent for a longtime friend who lives in the nursing home at Oakcrest Village. And I have just a few quick comments and then a question. One comment is, it would be wonderful if more men, young men, could be recruited into this field. Number two, I'm sorry. Number two, I think I loved a lot of the, I loved Holly's wisdom. I could really connect with a lot of the things that she said, having visited my friend in this nursing home for the last 3 years. I was surprised when, I think it was she that said that many of the GNAs or CNAs are older women. I didn't realize that. That was interesting to learn. And then I've been letting the director of the long-term care facility at Oakcrest know about these meetings. And I'm not sure whether he or any of his staff are attending, but I wanted to let you know that I think that these are such valuable meetings. And then this is a question for probably Robin. I think it sounds like she might be the most knowledgeable about things at the national level. Do you know to what extent elder care is on the radar screen for either of our presidential candidates?
I wish it were. I mean, Biden has certainly tried to invest. I mean, when he came in very strong with actually $400 billion proposal to really strengthen the frontline care professional workforce. And, the challenges that we have at the federal level with the executive branch and the legislative branch, so many things have to go through Congress that it is really hard to make anything happen. I wish, being a person who worked in the feds for many years, I think it is very, very difficult. I would say that it is within the framework of human capital infrastructure that Biden thinks about the importance of this workforce and the importance of elder care. I don't have a sense at all of the other candidate, the Republican side of the House, in terms of whether that's on the radar screen at all. But certainly it has been on Biden's radar screen. The other thing, of course, is that the unions have been very strongly supportive of Biden. And the union, particularly SEIU, has been a very strong supporter of this workforce. So whether it's going to be front and center above climate change, for example, or immigration policy, quite honestly, would affect us.
Yeah.
Even getting spouses to be able to be recognized. Every time a worker in our organizations who is an immigrant has something negative that happens, it affects the morale and the way in which our immigrant workforce works. So we have to understand how important these immigration policies are. So I would say Biden has been really strong in that area too.
Thank you. I guess it wouldn't hurt for us to send comments to him, to Biden.
No, definitely. I mean, they listen to it. I mean, Senator Casey has done, they have a new bill around workforce enhancement. They had on the Hill, they had a hearing. Jasmine Travers, who is one of the members of the Moving Forward Coalition, who is actually at NYU in the School of Nursing and does a lot of work on the direct care professionals, testified. So there is movement, but to be able to get that beyond that is not an easy thing. And hearing from the people is what, that's what it's all about. So it certainly doesn't hurt to send a message.
Thank you.
Thank you, Robin. And before we get to Sarah from PHI, we did have a question from Melanie Stiles. Melanie Stiles is with the ABLE Foundation. I know she had to leave, but I want to answer it in case she watches the recording. And she asked if it's common to have surveys of frontline staff. And I think you alluded to that, Robin. In fact, it is not common. Now, I do know that the National Association of Healthcare Assistants has in the last couple of years surveyed its membership. They have a membership of more than 20, I think it's, 20 to 30,000, mostly CNAs. So they do survey them regularly. And I think that data is quite valuable. But obviously having a much more at the national level, say from, like you said, HHS or CMS or somebody it would really be having that kind of support for that kind of data would be immensely helpful, of course.
Yeah.
So Sarah from PHI, welcome.
Thank you. Hi, Meg. Hi, everybody. Thank you so much for speaking. It's been really interesting so far. And I'm at PHI. I'm relatively new since January. I'm a research associate. And my question is about teamwork and that skill of teamwork that was mentioned a few times. And I'm wondering, as far as I know, that's not included in the official CNA training that happens before somebody actually gets hired and starts work. So I'm wondering if anybody can answer this who spoke, I guess, if that should be included as part of the formal CNA certification, or if that's something that employers would want support with training staff in. So sort of like at what point would it be most helpful for the skill of teamwork to be covered, I guess, and for it to be taught to people or for people to work on it?
At all levels, I think it should be a part of the basic training, because even in the basic training, you're in a class, you go and do your clinicals. It is a team approach, whether you're studying together, whether you're looking at what you're going to do together, and that has to be part of it. And customer service as well, the different demographic that we are dealing with, as Holly was doing this with the family members. We have a lot of family members that, because of the guilt, because they're anxious, because they don't know what to do, and it's hard to let someone else take care of your loved one. But how do we and our staff still continue to give them great service and sort of discard that roughness or bluntness or accusatory demeanor that they have towards staff? That is a skill, that is an education, that is something that should be reinforced more in school, but then also it should continue at the organization level as well. So both.
And I think that it should also be an exchange of acceptance of the resident being who they are, and that they're going to continue to decline. And once both get an acceptance that this is what we're here to do, then there's teamwork coming together. We're finally at ease that this is how mom and dad's going to be, and this is who we're going to have to take care of. And at that point in time, just do our job,
And I think what you're saying is expanding that team. When we first started talking about teamwork, it was internal employees,
right?
GNAs and GNAs, GNAs and nurses, but it's also, as you're saying, it is a collaborative of the families and the residents. Like, we all have to be on the same page to give that care. So the team expands.
My thing is,
oh, go ahead, Holly.
no, my thing is that when you go up on a unit and you're working with someone every day, my thing is that you're supposed to build a camaraderie. And in order for that unit to function sufficiently and efficiently, we all have to be of one mind. My thing is that a family member, I don't care what you do, if you go above and beyond, you are never going to be taken care of. They're not going to feel that you're taking care of their family member. I don't care if you are flying in the air. They're still not going to say you're taking care of them. But no, as far as the job, once you're on a unit, in order for a unit to run smoothly and also to make the employees feel comfortable, everybody has to work together.
Absolutely.
It's already stressful as is, stressful enough. And my thing is that you want employees to keep wanting to come to work, not only for the simple fact that you have a family to take care of, whatever, but also too because it's enjoyable. Because I know I'm working with this person today, and that we're gonna, you know what I'm saying? We're gonna get in there and we're gonna do what we have to do. And that's what it has to be. And I don't know if that can be taught. That's something that should already be ingrained. You know, like a perfect example. Whenever Melanie doesn't normally work on my unit, but sometimes she may get pulled to my unit. What I will say about Melanie doesn't sit herself off. She gets into the thick of it. She talks to everybody. She involves everybody. She'll come and she asks you, do you need help? Or whatever is like that. You know, it's never to the point where I'm just coming here to do my job and to go home. No, she comes in and she's like, I'm on this unit today. So guess what? I'm part of this unit today. And that's how it's supposed to be.
Yeah, and I think, you know, years ago, I mean, the sad thing is we have a lot of evidence, both qualitative and quantitative evidence and practices around this. 20 years ago, almost now, when PHI and Leading Age had a large national demonstration called Better Jobs, Better Care, Carl Pillemer at Cornell actually developed a team program to train families, CNAs, and frontline nurses together on how to work as a team. He actually did it. He had evidence to show outcomes. We have the program. We tried to get it out to all Leading Age members. The challenge is how do you get people to actually use what we know actually will work? And sometimes, Holly, you're so right. It just becomes it's natural and it's normative. Other times it has to be taught. And, you know, I think if I had one struggle with Survey and CERT is that I still continue to think it misses the point of what we need to be looking at for producing quality, because it's all about what we were just talking about. That's what produces quality. And we have to focus more on that in terms of where are the exemplars and how do we build this up in our organizations? And then how do we reward them with higher reimbursement, with better, you know, pay for performance that shows that these guys are really doing a great job? That's really, I think, what needs to be done. And right now, with the exception of a few, that doesn't really happen. But it is all about these relationships. And I love the discussion that you're having. And we do have trainings that actually will support that. So let's use them.
Okay, I'm going to interrupt. Now, Keswick does have that. Keswick has a program where either family members or nurses or supervisors who see your work, what they do is you do get rewarded. And I'm going to say it works because my daughter benefited from it. So it does. And she's only been there for 2 years. And, you know, everyone sees her work. So they do have a program at Keswick. I will say that. They have a program at Keswick that does reward employees for their example or their commitment. So I'm going to give Keswick a thumbs up on that. Not just because my daughter got it, but I'm going to give a thumbs up.
I think
that's great.
And I think the program you're referring, I know Keswick works with the Sika Foundation, which is based in Maryland, I think DC. They're an incredible organization that does really great work around recognizing direct care frontline staff. So,
yeah, I mean, we've got all kinds of programs. The problem is they don't become normative in terms of across the country. And when something bad happens, all places get painted with that same brush. You heard Regina say that they actually are above the staffing ratio. We have many of our, particularly in Leading Age, many of our members are above the staffing ratio. So, you know, how do we have a conversation around not playing to the lowest denominator, but trying to play to the highest denominator? I mean, how do we move towards the exemplar?
But then also again, Robin, as we were talking, how do we not focus on the number? How do
I
we
agree.
focus on
I
the
mean,
quality? Because there are times that
course,
I
it's-
could have 10 great that
completely-
could take care of a large
Mm.
amount of residents, but then we have days when we have everybody show up, there's 50 in the building and everything's going wrong.
That's
So
right.
you know,
It is. I mean, that's the whole point of relying on these ratios. I mean, there probably has to be some type of a threshold, but outside of that, it's not going to get us very far because it is the quality of the folks working together. We're a pretty flat hierarchy too in long-term care. It's not like a hospital that has a million layers.
Right.
We're relatively flat, which actually should give you more opportunity for teamwork.
Okay.
So,
Yeah. So thank you. Thank you, everyone. We are actually out of time. I could talk about this for the rest of the day. I really appreciate everyone's input. This is a really incredibly important discussion. Look for the replay. I will send everybody a recording, and look for our issue briefs, which will come out in the next few weeks. So thank you again, everybody. Have a good
Right,
afternoon. Bye-bye.
Bye.
bye, everyone.